Hello, my name is Sam Schiffman. I'm from Diameter Health, and today I'm going to be talking to you about converting data from CCDA documents to FHIR resources. Doesn't that just sound like so much fun? What I really want to do is tell you a little story about my friend Alice. But before we get into the story, let me tell you a bit about myself. I've been in the software industry for over 20 years now. I have experience as an engineer, architect, and even some time as a CTO. I've worked at a number of places you've probably heard of, like SunGard, ADP, Pearson, Diameter Health, and a few others you probably haven't. At Diameter Health, I've been focused on bringing actionable FHIR to patients, clinicians, payers, well really to everyone, including my friend Alice. She's an accountant at a bank. We met in college where she helped me get through calculus. We still keep in touch and go out for the occasional meal together. Last time we went out, Alice started having trouble breathing. It got bad really fast. Luckily, the hospital around the corner had just finished renovating their emergency room. As close as it was, by the time we got there, Alice couldn't even talk. The ER staff used her insurance card to look her up in the EHR, but Alice had never been seen in that health system before. Luck was with us, though, and the newly updated EHR knew how to use FHIR to reach out to the local HIE and her health insurance to request her medical history. They, in turn, had data from clinicians that had seen Alice in the past. However, this data was in the CCDA format. In order to provide that to the EHR, it needed to be converted to FHIR. But more than that, it needed to be made actionable. As we will see, simply dumping the data into a new format wouldn't have helped Alice at all. Her doctor needed to be able to interpret that data fast enough to take action on it. So let's talk about some of the challenges in turning CCDs into actionable FHIR. We're going to step through each of these in more depth, but at a high level, the problem is both one of mapping terminologies and handling the new realities of interoperability with the multi-source data that comes along with it. To solve these problems, we will see that we need to both normalize and deduplicate the FHIR resources before handing them over to a clinician. So first, let's talk everyone's favorite subject, terminology. In the world of CCDA, we see many code systems in use. For example, we use LOINC to code laboratory tests and results, ICD-9 and 10 for problems, and SNOMED-CT for, well, all kinds of things. And these are only some of the code systems we see in the wild. As HL7 has built out FHIR, they've introduced a number of new code systems, especially for use in FHIR resources. The problems start with the fact that code systems in CCDA often map to multiple places in FHIR. For example, HL7 v3 ACT status maps to multiple different statuses in different FHIR resources. So we need to maintain a complex mapping from one system to another. However, it doesn't stop there. As we all know, code systems are not static, so our mapping has to be able to evolve over time. As if this wasn't enough, there are holes in the mapping. For example, the active status has no mapping in observation, but it's still legal in the CCDA. These holes can lead to data loss. At Diameter Health, we engage expert in-house terminologists to make sure we are delivering the most actionable data possible from the sources we are given. Another big challenge is due to the promise of fast healthcare interoperable resources themselves. Alice's case is a perfect example. As FHIR starts to deliver on its promise, doctors start to have to drink from the fire hose of data. In the past, clinicians were restricted to the trickle of data available in their EHRs. While it might have been limited, the data was generally consistent. For example, two CCDs from the same EHR installation will generally use the same code systems for, say, a medication. So, they might have been drinking out of a thimble, but the water was pure. But in Alice's case, the data was coming from multiple sources, each with their own way to code things. At Diameter Health, we've seen this in the wild. Here, we are showing 5 different ways the same medication can be coded. Now they are drinking out of a hose, but is the water clean? To act on the data, the doctor needs to recognize it for what it is. In other words, actionable data must be clear. And it's not just medications. Here we are looking at the same problem coded 3 different ways. We can easily see how difficult wading through these mounds of data would be. Alice's ER doctor doesn't have time to interpret it all, so he's in danger of going into information overload. If this happens, he may well start to gloss over important information. After all, Alice isn't breathing. He doesn't have time to cross-reference codes in his head. Now the data is at best useless. To make it actionable, it needs to be presented in a concise and consistent manner. So how do we do that? Well, at Diameter Health, we take the data through a process of normalization and deduplication. Let's look at how that plays out. Here we are looking at 4 of the ways that same medication was coded. We would show 5, but they wouldn't let us use the IMAX. The first thing we do is normalize the codes to the corresponding RX norm code. This gives us a consistent code system, and in this case, a consistent code across all the medications. Next, we identify clinical classification for the codes. This helps us not just in deduplication, but also aids in decision support down the road. We next look at the medication directions, or the SIG. From this, we can glean information like the dosage, form, route, and so on. Now we have a consistent full view of these medication entries. We can see that they are the same medication. This allows us to boil down all 4 or 5 entries to 1. And here we have it, truly actionable data. We reduce the 3 problems to 1 condition and the 5 medication entries to 1 prescription. At a glance, the doctor can now see Alice's medical history instead of a bunch of noise. For Alice, this was a lifesaver. The doctor was able to quickly move past the diagnosis of anaphylactic shock, which was a perfectly reasonable diagnosis for a patient that presented with trouble breathing after eating at a new restaurant. But from her medical history, he could clearly see that acute asthma was much more likely. Armed with this actionable data, the doctor made the right call, and Alice got home a lot faster. So what have we learned from Alice's story? I don't think we can overestimate the potential benefits of FHIR in the medical industry. In a world where data is the new oil, FHIR represents the holy grail of interoperability. But simply connecting the pipes isn't enough. What is flowing in those pipes is just as important. If we are going to realize the power of FHIR, we need to be realistic about the challenges involved in making data actionable. At Diameter Health, we've learned that we need to pay attention to terminology mapping, normalization, and deduplication when we convert data from CCDs to FHIR. It's not that these problems don't exist in CCDs. They do. But FHIR will open the floodgates of interoperability. If clinicians are going to withstand that surge, they need to be receiving the highest quality, most actionable data we can give them. Now you might point out that my story about Alice is fictional, which it is. We don't yet have EHRs that can do this. But with the recent ruling from CMS, we will soon have patients carrying around this sort of data on their mobile devices. EHRs leveraging that data can't be far behind. This will start to unlock the mountains of clinical data already in the medical industry. It's critical when that data is provided, be it to a clinician, patient, payer, well, to anyone, that the data be actionable. So I hope you will join us in a quest to light a FHIR, actionable, fast, healthcare interoperable resource.